Now it's my great pleasure to introduce Dave Anderson, President and CEO of Blue Cross Blue Shield of Western New York and Blue Shield of Northeastern New York. Dave leads the region's largest health insurer, which is a community-based nonprofit plan with 1 million members. And Dave is really a forward-thinking entrepreneur and executive, and he's leading a number of innovative efforts to improve the health of New Yorkers, including a community outreach campaign to address the opioid epidemic and a unique home-based care program with behavioral and social supports. As you'll hear today, Dave is committed to strengthening the primary care to support improved care, better population health, and lower health costs. And he has led the development of an innovative new payment program to empower primary care providers with flexibility and resources to better manage their patients' care. So please join me in welcoming Dave to the podium.
I've enjoyed the comments of our prior speakers, and I think the sequencing is good. Michael is more of a macro level and talking conceptually. I think Curtis's comments were specific to Arkansas and to those segments, and so I want to spend a little time today talking about a very specific market-based, value-based initiative that we have brought to that market called Best Practice. It's very regionalized, and it is also focused on to help the primary shortage of primary care that we have in that area of Western New York. So I'll give you some context around the population that I'll be talking about and the area. This is us, headquartered in Western New York. We operate at our headquarters in Buffalo. Western New York is an area that has actually had some shrinkage in population over the past decades, and its population is aging a little bit. So those are factors in the efforts that we have made to transform that population. This is where we're located. Again, I'm going to talk specifically about Western New York, although we will begin to roll out similar processes in other locations as well. This is the region that we focused on. It's an 8-county service area. As I mentioned, it has static population trends. There are 2 major hospital systems in that area and controlling about 80% of inpatient care. And there is one distinct cancer specialty hospital, Roswell Park, is in that area as well. Fairly typical of legacy territories that are hospital-driven. They are very doctor-centric, not patient-centric. And as we have evolved into more of a patient-centric and consumer-oriented segment in healthcare, we have a need to flip that around. We looked at the area and said, how can we begin to transform the provider systems in this specific area to make it more patient-centric and to bring value-based contracting to the region. There was a very high degree or concentration of specialists, also not that unusual when you have hospital-driven communities, and they were very much a late adopter to any form of reimbursement other than fee-for-service. Our program is called Best Practice, and it really had 2 main objectives. One, to transform into a value-based and provide and realign incentives with our provider system, as both Michael and Curtis had talked about. And also we have a pretty critical shortage of primary care physicians in Western New York, and you can see the numbers there showing our deficit. And they are shrinking all the time, not unusual in a number of communities around the country because they have not been supported either economically or within their practices in a way that makes primary care the preferred specialty, if you will, in the provider system. As I mentioned, we had an aging population, And the result of the model, the fee-for-service model, caused primary care physicians to be reimbursed and their income levels to be such that they have a general incentive to move towards specialties. And in a volume-based reimbursement model, the only way that primary care physicians can progress is to do more volume, which is exactly the opposite of the incentives that we wanted to provide. So the current relationship is broken. Much of this you know and you've heard. The responsibility of our system in a fee-for-service world really falls on the patient. PCPs, our primary care physicians and specialists, do not collaborate as well as they should. Often electronic medical records and other forms of patient records don't follow as concurrently and as accurately as they should. That results in redundant testing and procedures. And there's also, in a fee-for-service environment, an inability to really reward PCPs based on their performance. Essentially, they're all reimbursed in the same way. And the result that we have today is our higher cost, lower patient satisfaction scores, very difficult to measure quality scores in that environment. And so we have moved forward towards best practice. This is primary care as we felt it should be. It's not perfect, and we did not want to go from A to Z all in one year. I don't think that would be possible, but I think it's a really good step in the right direction. First of all, the PCP coordinates care and would be compensated accordingly, and I'll get into that in just a second. And to have a PCP assignment does not have to be an HMO-type plan where it's chosen. We use a McKesson tool to attribute all of our members to certain PCPs such that they have a full panel. We focus on the total health, which I think should become apparent in a minute, not just treating illnesses. The PCP becomes the source of referrals, and we provide support. We have changed our provider support model such that the PCP has concurrent data to share with specialists. The net result of the financial model is it will reward outcomes. We have already seen higher patient satisfaction scores, and we are early. This program that I'll display here in a second started January 1st, but we are already beginning to see, primarily because of changes in referral patterns, we are beginning to see costs decline. So functionally, and I'll apologize for the granularity of some of this, but I think it's important that you know functionally what value-based contracting can mean. It's not the only model for it, but it's a terminology that we use a lot. But to bring it right down to a relationship between the health plan, the member, and the provider, I think is important to understand. We launched ours in this 8-county area on January 1st. We actually started the April before and began educating the PCPs in our region for 9 months prior to implementation. We now have 1,000 PCPs participating, and we have about 400,000 of our members attributed to those PCPs. One of the disadvantages, although conceptually ACOs and ACO-like arrangements or even patient-centered medical home arrangements, one of the downsides is they generally work on smaller populations. They're specifically about a named population. It might be a segment-based, it might be very small regional basis, or whatever that particular provider group can provide care for. We wanted a bigger effort than that. We wanted to transform the membership in an 8-county area across the board. So one of the things that we have been able to do here is we're including Medicaid, we're including Medicare, and we're including our employer population, whether it's self-funded or fully insured. So it has a broader impact across the population. What we've done is we've created a combination of fee-for-service which we have just been saying is a bad thing, and I know we've been saying that all morning, but there are aspects where fee-for-service actually works, and as well as a monthly payment that we refer to as a care management fee. Also, because Michael indicated that we don't want to use capitation anymore, so we refer to it as a care management fee, but I have put capitation back into this explanation on purpose because I think it makes the point, although it is not capitation in the way that most of us remember it. So here's generally how it works. What we did is we took those 400,000 members. We looked back over a 2-year period of time. We started in 14. We have that claims data. On a per member per month basis, we created a base rate and said the cost of that population historically on those claims under that traditional model is a certain amount per member per month. That's our base rate. We then used a form of capitation adjustment, which has historically been age and gender related. That's nothing new. But what we've then did is we used the McKesson risk scoring tool, which looks back at scoring and then can actually begin to predict what costs will be based on an individual score. And we applied those factors for every one of those members. So for example, a primary care physician has 100 of our members. He actually has a risk score that is different for every one of those 100 members, based on whether they have chronic illness, based on whether they're very well, based on their age. It determines. So they are all different. We then take that population and we look to the providers. We use our HEDIS scoring methodology, and we create 10 guidelines within our HEDIS reports, and we apply those against the factor on a per-patient basis. Now, we could debate HEDIS. HEDIS is not perfect. However, we find that we've used the 3M system, risk scoring system as well. We found the results of those two analyses to be fairly similar. So we are fairly comfortable that using our HEDIS scores was an adequate a measure of quality. And we also, because of our work on Medicare Advantage, like most health plans, we are having to do the HEDIS scoring methodology and do the code checking as well. So that seemed to make sense, and we've had reasonable accuracy with that. And then on the efficiency model, we use the McKesson risk scoring tool for that because it has a prospective measure to it. And we combine those two, and that is applied towards every one of those members' risk score. What that creates is, and I have the word capitation there, but that's our monthly service fee. What that creates is an actual capitation or monthly service fee to the primary care physician, which is unique to every one of the patients that is attributed to that PCP. And as I said, there are a number of things, particularly in the preventive and wellness areas, that we want to have happen, and we continue to pay them on fee-for-service. So that creates the reimbursement model for the primary care physician. We believe everybody wins. I won't read everything on the chart. It's certainly available if you'd like to have it. But one of the things it does, it creates a baseline level of cash flow for a primary care physician to be able to build their practice and to know that they have a certain income level that they attributed to their patients that they can count on. And there are factors in that base level of compensation that then allows because there's revenue there every month for a physician, it allows them to manage their patients the way they think it's best. And a good example is under the traditional model of fee-for-service. In order for them to receive any compensation for a consultation, the patient has to come into the office. may not be necessary. This way, if they want to use telephonic or video conferencing to communicate with their patients around conditions that are not as severe, there's actually a piece of that service fee that contemplates that, and they feel that they have adequate compensation in order to adjust their practice accordingly. They also have access to cost and quality data that they traditionally had not had. And that cost data is important in the referral pattern process. Most times what we had found is a primary care physician making a referral to a specialist at one place or another had no idea of what the cost, quality, and efficiency measures were for the specialists they were referring to. Now, that's a work in progress, but we are already seeing a difference in the referral patterns against this population from the primary care to the specialist, and because that, as wellness and health of that population improves for those patients that are attributed to that primary care doctor, then he begins to receive more money because of the way that the monthly service fee is calculated. And his reimbursements go up. He's rewarded for the higher health status of his population. So he wants them to go. He wants his patients to go to the most effective, highest quality environments they can to receive their care. Historically, he did not know where that was. The member, they're dedicated to a PCP. Generally, we find our members, although choice is always important, want to have a PCP that helps them guide this through the system. The care is not limited to a standard office visit, as we mentioned. It's up to the physician and the patient to determine how that care, primary care, would be administered. It is better coordinated, so when they leave their primary care on referral, their records are largely supported and they're very current. And that allows the member to have shared decision-making with their PCP. On our side, on the payer side, it is aligned with our HEDIS measures and affects our risk scoring, can affect our risk scoring for risk adjustment revenue, as well as star ratings. There's a greater focus on population health. And as I mentioned, one of the things we've seen that we've underestimated a little bit, there is a change in referral patterns to more cost-effective specialty environments. So it's a major step from fee-for-service. Western New York was very traditional. I arrived there about 4.5 years ago. There was essentially no value-based contract in the market at all. So it was a territory that had lagged a little bit, and as I mentioned, we now have 90% of our PCPs and essentially all of our attributed population on the basis of that contract. I mentioned we spent 9 months educating in advance. One of the critical things, I heard Curtis say the same thing, that it is essential in these environments that you change your provider support model. They need data in a different way and in different timing in order to make the right decisions over what they have had in the past. We've added about 25 provider service representatives that do nothing but administer these contracts with those 1,000 PCPs. So outcomes, as mentioned, 90% are working with us now. We believe, well, we were told directly by CMS that we were awarded a CPC Plus contract as one of the 14 pilots for 2017, specifically because of our best practice program. I'd hoped I'd had a little runway in this process, but my largest competitor has copied us almost already. And I guess that's a way of saying that we feel we made some of the right decisions. And then after 1 year, we're not quite done with the year yet. What do we expect to see? We have a higher degree of cost transparency at the PCP level, and that's also helping them make appropriate referrals. We have, as I mentioned a couple times, the change in the referral patterns as a result. We have a very different level of provider engagement, and our value-based literacy among PCPs, which they didn't know even 2 to 3 years ago. And we've seen HEDIS score improvement greater than traditional pay-for-performance programs, which has helped us in risk adjustment processes as well as our star rating. As far as actual savings, what we're looking at, we're pretty aspirational. We think probably on an overall basis around 2% in 2017. We don't know that yet. It looks like that's about what we're tracking. And again, I think I agree with the comment Michael made, that may not seem like a lot. It seems like a lot of work and a transformation of entire provider system for 2%. But this is a multi-year arrangement. And we think in year one that would really be excellent. And remember that in a compounding environment, the 2% savings resets the baseline. So as you move that forward, that 2% becomes very significant over time once that baseline is continually is reset. So that's best practice. We'll hopefully have a chance to come back and report towards the beginning of next year after we have a full year in. But hopefully that was helpful to give you some granularity around how some of these concepts are applied at a market level. And thanks for having me. Appreciate it.